All right, welcome to This Explainer. Today, we're diving into a literal biological whodunit hidden right inside our own bodies. We're going to unravel the complex and honestly incredibly deceptive connection between shoulder and neck pain. It's a mystery that routinely stumps even seasoned surgeons, and we're going to look at the amazing science of how they actually crack the case.
So, you know that nagging shoulder ache? The one that keeps you, or maybe an older relative, tossing and turning all night? You rub it, you ice it, you rest it, but nothing works. Well, what if I told you that in a lot of these cases, the real issue is miles away from where it actually hurts? What if your shoulder is screaming, but it's your neck doing all the damage? To wrap our heads around the sheer scale of this problem, let's look at the numbers. Consider this. Roughly 19% of adults aged 45 and older are dealing with neck pain. That is nearly 1 in 5 people just walking around with a cervical spine issue.
And on the flip side, up to 26% of people experience shoulder pain. That makes it the third most common musculoskeletal complaint overall. With such huge numbers of people experiencing both of these issues independently, it's basically a mathematical certainty that these conditions are going to crash into each other all the time.
All right, let's get into Section 1, the phantom pain. It's basically like crossed wires. The neck and shoulder are so tightly packed together anatomically, with so much muscular and neurological overlap, that pain signals easily get mixed up. Patients will come into the clinic absolutely convinced they have shoulder pain, when in reality, structures in the neck, like the levator scapulae or the neck extensors, are the ones crying out for help. Plus, in older patients, rotator cuff and cervical spine issues commonly happen at the exact same time, creating these overlapping, frustratingly vague symptoms. Moving right along to Section 2, red herrings. Every good mystery has a few false leads, right? Well, in medicine, doctors face 4 massive hurdles when treating tandem shoulder and neck pain. First, as we just saw, the symptoms completely overlap. Second, clinical exams for the spine and the shoulder just aren't perfect tools. They lack the independent sensitivity to always make a definitive call. Third, MRI findings can be notoriously nonspecific. And fourth, electrodiagnostic studies, like nerve conduction tests, are surprisingly unreliable for diagnosing things like pinched nerves in the neck. So, standard tests frequently fail to point a clear finger at the true culprit. And honestly, this is the wildest part. An MRI is a pretty unreliable witness. Studies show a staggering 25% of perfectly healthy, pain-free people over the age of 40 actually have a disc herniation or foraminal stenosis on their cervical MRI. So they have these terrifying-looking bulging discs, but literally don't feel a single ounce of pain. Crazy, right? Basically, it boils down to this. Just because you see a scary abnormality on an MRI doesn't mean it's the actual source of the patient's pain. You can't treat an MRI scan. You have to treat the human being. And that requires doctors to deeply connect physical findings with the images they see. It's a hugely nuanced skill.
Which brings us to Section 3, the ticking clock.
Now, a torn rotator cuff hurts, no doubt about it. But some neck issues, they are literal emergencies. Specifically, cervical myelopathy. This is a compression of the spinal cord in the neck, and it acts as a ticking clock because it can lead to permanent, unrecoverable functional loss. Since patients often don't even realize what's happening until it's really severe, doctors meticulously look for specific physical exam clues to sound the alarm. They're checking for functional anomalies, like the finger escape sign or a spastic gait pattern when walking, or pathological reflexes like the Hoffman sign. But look at this tricky little inverse relationship here between the sensitivity and specificity of these reflex tests. A test might be highly specific, meaning if you have the sign, you almost certainly have the disease, but it could be poorly sensitive, meaning plenty of people with the disease won't show the sign at all. Because of this, doctors actually have to cluster these functional assessments and reflex tests together to figure out if a spinal cord emergency is lurking beneath the surface. All right, Section 4, the detective's toolkit. So with all these false clues and ticking clocks, how do doctors actually figure out the root cause? Well, surgeons use an evidence-based clinical algorithm. When both the shoulder and neck show pathology, they'll often use diagnostic injections. By injecting a temporary numbing agent and steroid into one specific area, say the shoulder, and observing if the pain just vanishes, they can essentially isolate the main pain source. It's a brilliant process of elimination. Ultimately, treatment comes down to a really strict hierarchy of priorities. First and foremost, you absolutely must rule out cervical myelopathy. If those spinal cord compression red flags are flying, the spine is the #1 priority to prevent permanent nerve damage. Second, if there's severe radiculopathy, like a pinched nerve causing profound weakness, the spine takes precedence again. But step 3, if both conditions are there but neither is an emergency, fixing the rotator cuff first is generally the way to go, since it's typically a less risky surgery.
Let's look at some real-life examples in Section 5, Case Files. Let's ground all this theory with some actual patient stories to see this detective work in action. Meet case number 1, a 73-year-old woman presenting with chronic, worsening right shoulder pain and severe weakness. Her imaging showed a legitimate 2-centimeter full-thickness rotator cuff tear. But there was a massive clue in her medical history. Her pain was radiating past her elbow and down into her fingers. And let me tell you, pain radiating past the elbow is a classic red flag pointing away from the shoulder, hinting heavily at a neck issue.
So the doctors ordered new imaging of her neck, and boom, there's the twist. Despite the torn rotator cuff, her severe, debilitating pain was actually caused by loosened hardware in her neck. Screws from a prior cervical fusion surgery she had 9 years earlier had actually pulled out. The shoulder tear was real, but it was a total red herring. To fix her, they had to revise her neck hardware, not touch the shoulder.
Okay, case number 2. This is about a 69-year-old woman who had been suffering from right shoulder pain for 3 whole years. She'd been getting shoulder injections, but they were working less and less. By the time she reached a new specialist, she was actually confined to a wheelchair because of frequent falls and balance issues. Her shoulder surgeon astutely noticed her reliance on the wheelchair and, thankfully, ordered an urgent neck MRI. And what they discovered was horrifying. Severe central disc protrusions causing massive spinal cord compression. This was that hidden emergency we talked about earlier, cervical myelopathy. She needed prompt, immediate neck surgery to decompress her spinal cord. It wasn't until months later, once she was neurologically stable and out of her wheelchair, that they finally fixed her shoulder. Now, this brings us to our final case, which perfectly illustrates the hidden danger of ignoring the neck entirely when planning a shoulder surgery. A 66-year-old woman came in with a torn rotator cuff. She had a flawless, totally standard arthroscopic rotator cuff repair. But 9 months later, the repair completely failed. Why? Because she had an underlying, untreated neck condition causing chronic nerve issues. That compromised nerve signaling likely caused the repaired shoulder tendons to fail entirely and retract all the way back to the bone. Because the neck was ignored, the shoulder failed, and she ultimately needed a massive reverse shoulder replacement.
This whole explainer really hits the nail on the head. Treating the human body means looking way beyond the obvious symptoms. As our source material firmly concludes, shoulder surgeons should seek cervical disease with a high index of suspicion. You just can't operate in a silo. You've got to understand how these anatomical systems overlap. So what's the big takeaway here? It's a newfound appreciation for just how interconnected your body actually is. Next time your body sounds an alarm, whether it's a nagging shoulder or an aching joint, will you know where the fire really is, or will you just chase the smoke? Always be prepared to ask your doctor to look a little deeper. Thanks for hanging out with me for this deep dive. Keep questioning, keep learning, and I'll catch you on the next explainer.